Hi, my name is Jacqueline Garcia. I'm an adult leukemia clinical investigator at Dana-Farber Cancer Institute in Boston, Massachusetts. At ASH 2020, on behalf of my colleagues, I presented Abstract 170, which is data from our phase 1 clinical trial testing Decitabine plus Ipilimumab in relapsed or refractory MDS or AML in patients who either post-transplant or transplant naive, and we present the safety and preliminary efficacy. This trial launched because of the preclinical and clinical data demonstrating activity with single-agent Ipilimumab, and we asked a question of whether or not we could increase responses without incurring too much immune toxicity by the addition of Decitabine. And so our phase 1 trial is sponsored by CTEP. It is multi-site. And very fortunately, what we did was we separated the study by 2 arms. And so patients entered study and were assigned to an arm based on their transplantation status. They were either post-transplant and they went to arm A if so, or transplant naive and they went to arm B if so. All patients received the same therapy, which will allow for comparison and toxicity between the arms. So patients who had either relapsed, refractory, or secondary MDS or AML, they could have received prior hypomethylating agent. They received a month of Decitabine at standard dosing, followed by Decitabine plus Ipilimumab. So there was a lead-in period of 4 weeks with just Decitabine at standard dosing alone. And then patients that made it through that first cycle without GVHD incidents, they were able to move forward with Ipilimumab in combination with Decitabine at standard dosing. Ipilimumab was assigned in terms of dose level based on, Ipilimumab was dosed based on dose level assigned, and it was either at 3, 5, or 10 mg per kg. And treatment with Ipilimumab was given with Decitabine every cycle, and each cycle was 28 days. If patients had at least stable disease or better, they could then enter what's called a maintenance phase, where patients would receive continuous Decitabine every cycle, followed by, with the addition of Ipilimumab every other cycle. But the primary objectives of this study was looking at MTD and recommended phase 2 dose in these 2 separate arms based on transplantation status. And secondary objectives include looking at preliminary efficacy and induction of GVHD. The dose-limiting toxicity window was long. It was 8 weeks, and it started at the first dose of Ipilimumab. So the dose escalation portion of this trial was very slow, purposely so we could capture immune toxicity. And DLTs included any study treatment-related death, acute GVHD that's grade 3 or higher, non-heme grade 3 toxicity that was not due to underlying disease. And events that were not a DLT were grade 3 immune toxicity events that rapidly responded to steroids and resolved or improved within 4 weeks. The baseline characteristics of our 47 patients that were on study at the time of this presentation are as follows. We evaluated 25 post-transplant patients, and among those, the median age was 67. 88% had acute myeloid leukemia, 68% had prior HMA therapy, so pretty heavily pretreated. Patients who were transplant naive in arm B, that included 22 patients, and among those, the median age was 75. 64% had AML, 36% had MDS, and 64% received prior HMA therapy. The non-heme, non-immune toxicities, the profile looked very similar to what would be observed from underlying Decitabine or disease. But when we took a look at treatment-emergent immune toxicities, because a CTLA-4 blockade agent was included, we noted that in Arm A, which is the post-transplant cohort, 21 patients received Ipilimumab, and of these 21 patients, the immune toxicity rate was 38%. Most events occurred at Ipilimumab at 10 mg per kg, which again was our highest dose level tested, and one of these events was declared to be a DLT. And this was one patient that had acute GVHD grade 3, whose course was unfortunately complicated by septic shock later on. Other events that occurred in terms of immune toxicity within Arm A or post-transplant included 2 incidences of moderate chronic GVHD and 1 severe chronic GVHD. These events were controllable and treatable with immunosuppressive therapies. In terms of the transplant-naïve or Arm B cohort, of the 16 patients that received Ipilimumab therapy, the rate of immune toxicity was 44%. This again was seen most heavily in the Ipilimumab at 10 mg per kg, and it was indeed reversible in all cases except for one This was in a grade 4 thrombocytopenia, HLA refractory, what we call as an ITP, potentially related event. HLA refractoriness does occur in our MDS and AML patients after frequent transfusions, but as it was new onset, we counted this as a DLT. So we had one DLT in the post-transplant group at 10 mg per kg and one DLT in the transplant-naïve group at 10 mg per kg. No MTD was reached, and we identified Ipi at 10 mg per kg to be the recommended phase 2 dose. Objective responses were observed. For instance, in the post-transplant group, 19% of patients had an objective response, including 3 complete remissions and 1 marrow complete remission. Median time to response was 1.7 months. Impressively, 100% had prior HMA therapy, and only half of these responders had any incidence of immune toxicity. Among those in Arm B, or those that are transplant-naïve, the objective response rate was even better. It was 56%, and this includes 4 complete remissions, 2 CRIs, and 3 marrow CRs. The median time to response was longer than what we observed in the post-transplant group. Here it was 3.9 months. 56% had prior HMA therapy, and 22% had immune-related toxicity. The median overall survival in Arm A was 7.6 months. The median overall survival in Arm B was 18.3 months. Dose expansion is still ongoing. We shared some of the early correlative studies where we demonstrated using multiplex immunofluorescence that in some of the individual responders, we were able to track a T-cell infiltrate that was cytolytic based on granzyme B, CD3, CD8 co-staining after ipilimumab therapy among responders. And in non-responder, we are able to track T-cell infiltrates that don't have cytolytic capacity based on granzyme B co-staining, or the absence of granzyme B co-staining. We further shared some of the early multiparametric flow cytometry findings from blood samples collected at patients that received ipilimumab at 10 mg per kg. We assessed patients using large panels of 10 or more markers that were collected at pretreatment, after decitabine alone, and then after decitabine plus ipilimumab or combination therapy. And we were able to demonstrate is that after ipilimumab combination therapy, there are a couple findings. One, significant increase in ICOS positive T cells. This has been reported in prior checkpoint inhibitor therapy and leads to enhanced sensitivity to CTLA-4 blockade. We further saw reduction of naive T cells and an increase in memory CD4 T cells. And this was specific to the time frame of after ipilimumab therapy. And this was seen regardless of response. So overall, here we present the safety, preliminary efficacy of decitabine plus ipilimumab. We report frequent immune-related toxicity and objective response. Notably, response did not require immune toxicity, and the serious events were low. And so although immune toxicity was frequent, most were controllable, reversible, and the serious events were low. Additional correlative studies are underway to further elucidate the mechanism of responses and to help us to identify potentially patients that would respond better than others.